All right, good morning. Welcome. My name is John Donadio. I'm the Executive Director of the New Jersey Association of Counties, and again, want to welcome you to our virtual workshop today. This morning is on Medicaid and assisted treatment services. We've got a terrific presentation here from the Pew Charitable Trust. And before I introduce our esteemed guest speakers today, just a couple of housekeeping items that I want to take care of. This course has been approved for continuing education credits, so please make sure to contact Lauren in our office and she will email your certificates accordingly. If you have any questions throughout the course of the presentation, please put them in the Q&A icon on the bottom of your screen. There will be links to the websites for the Pew Charitable Trusts throughout the presentation in the chat room, so make sure to look for them. Please don't put the questions in the chat room because we're also going to communicate if we need to there as well. So again, all questions in the Q&A. I don't need to tell you where the restrooms are. We don't need that because it is virtual. And I do want to thank Angela Wolf again for doing just a great job in managing these virtual workshops for us. So with that, I am very pleased to introduce our two guest speakers today from the Pew Charitable Trust. And the first is, I'm just thrilled to see her. Many of you, I'm sure, had a great experience in working with Beth Connolly, who was commissioner of the Department of Human Services, spent 2-3 decades in Trenton, serving the state's most vulnerable population. She's currently directs the Pew's Substance Use Prevention and Treatment Initiative, and I'm just, she's just awesome, and I'm glad that you can join us today, Beth. So, and next up, and Brendan, you're not going to get as good as an introduction. I mean, I'm sure you got a great resume. I saw it, but I love Beth, and we just met, and you seem like a great guy. But Brendan McEntee, and I did pronounce your name right? Excellent. He manages the state technical assistance team for Pew's Substance Use and Treatment Initiative. He previously served as the director with the American Society of Addiction Medicine and with the Smart Growth America as a federal policy fellow. So Brendan and Beth, thank you both for being here today. And I'm going to turn over the show to you.
Thank you, John. It's really a pleasure, and I'm sorry that I can't see all of you because I was really hoping to see some familiar faces, but I know you're out there, and I'm so happy to be able to speak to you today. And I first want to say that for those of you who know me, I usually do not have 2 stripes on my head. But I took a little spill here in DC because suburban Jersey girl, when she's down here in DC, I tend to look this way and not look where I'm going. And I tripped over one of those scooters in the middle of a sidewalk. Took a good header. Fine, but I do look a little different than you all are probably used to seeing me. So thank you today. Brendan, did you have anything before we kick it off?
No, I go ahead, Beth.
Okay, great. Then let's jump right in. So today we're here to talk to you about work that we, the Pew Charitable Trusts, are doing in New Jersey. And I'm going to start by giving you sort of an overview of the work at Pew and a broad overview of our work in general. And then I'll hand it over to Brendan, and he's going to walk through what exactly we're doing with New Jersey in the counties and specifically in the county jails. So we can fast forward a couple slides. Perfect. Okay, so for those of you who don't know, the Pew Charitable Trust is a nonpartisan nonprofit, and we seek to bring evidence-based policies into the public sphere in order to really create a better society and create better citizens and better operating at the state level. Everything we do is based in rigorous research and evidence. And Pew itself is divided into 2 main pieces. One focuses on the environment, and the other focuses on government performance. And our office, the Substance Use Prevention and Treatment Initiative, is housed in the Government Performance Office. The Pew has actually been working in New Jersey in a couple of places. So some of our environmental team who looks at flooding and oceans, have done work in New Jersey, and our state fiscal health and pensions teams have also done work in New Jersey. The focus of the Substance Use Prevention and Treatment Initiative is threefold. First, we have a small project that we look at some opioid prevention and treatment programs that are actually at the local level, and we're working on an evaluation of these that are already looking to have some good evidence that we think can be scaled and brought into evidence base for more folks to use and to recognize these opportunities and something that they might be one to use in their own state, in their own community. And that work is done in collaboration with Robert Wood Johnson. We have federal work that we do, federal advocacy, and that's on two fronts. The first is we are advocating for the elimination of the X waiver. And for those of you not familiar with treatment and the provision of treatment, the X waiver is required by DEA and SAMHSA in order to prescribe buprenorphine, one of the three medications that are approved by the FDA for treatment of opioid use disorder. There is no other medication, controlled substance, that requires a waiver of this sort in order to prescribe. And in fact, buprenorphine, when used for pain, does not require a waiver at all. So you can prescribe all the Oxycontin you want, you can prescribe all the Percocet you want without any type of a waiver. But in order to prescribe this life-saving medication for opioid use disorder to treat it, the federal government has required that doctors and practitioners receive a special waiver. And this is clearly a barrier to people receiving treatment because it's a barrier for practitioners to obtain this waiver. So we are advocating at the federal level for elimination of this waiver. The other piece of advocacy we're doing at the federal level involves the relaxations that the former Trump administration provided at the beginning of COVID. And these COVID regulatory relaxations were provided to increase access to treatment during the pandemic. And they involve telehealth being permitted to be reimbursed through phone, so just regular phone, FaceTime and other platforms, Zoom, so that people wouldn't have to leave their homes in order to receive their counseling. They're also allowed for the prescribing of buprenorphine via telehealth. So initiation of buprenorphine via telehealth. And then in terms of methadone, one of the other three FDA approved medications for opioid use disorder, the federal government expanded the allowance for take-home medications. For folks not familiar with methadone and the provision of methadone, opioid treatment programs are the only place where you can receive methadone. And often it requires people to come every single day to the OTP in order to receive their methadone. During the time of COVID, especially in the beginning of the pandemic, this was unsafe for both patients and practitioners. So the federal government permitted this regulatory relaxation for take-home medication and also for the delivery of medication for people who may have COVID or should not, especially people who are very compromised who shouldn't be out during and interacting with folks. So that's the other place where Pew is as advocating. We have a paper that we just released that we worked on with George Washington University. We funded it, and that really details a lot of it, and that can be found on our website, which you'll have the link to later. And finally, the third piece of work that we do is state technical assistance. We have provided work to 10 states, technical assistance to 10 states, plus the District of Columbia. And our state technical assistance focuses on eliminating barriers to accessing treatment for opioid use disorder. So if we go to the next slide. So I'm sure a lot of you have, if you're not experienced it, I know from what John told me, who is participating in this call, I know that a lot of you are seeing on the ground the epidemic within the pandemic, and that overdose deaths during the time of COVID are actually increasing. People are feeling, isolated. Folks are not, maybe not receiving their treatment, but the number of overdose deaths is actually increasing. And this chart is provided by the CDC and just shows the provisional data through part of 2020, and you'll just see that these overdose deaths are increasing. The next slide. So just to reiterate, that 13.3% of adults have said that they have started or increased their substance use in order to cope with the stress related to the pandemic. And for the year between 2019, June, and 2020, 81,000 deaths have been attributed to overdoses. And that is an increase. We know that in 2019, that there were 71,000 deaths, overdose deaths due to substance use. So we're seeing this really striking increase in overdose deaths, which means that getting people to treatment, getting people to evidence-based treatment is really critical during this time. So the next slide. So these two links will be in your chat. And so there are two videos, both are really important. And so I hope you'll take the time after this, this presentation to go and look at them. The first video really talks about opioid use disorder and as the chronic disease that it is. So opioid use disorder is a chronic disease. It's like asthma, like diabetes, like hypertension, and there's FDA approved medications that can be used to treat this chronic disease. And so the first video will really walk you through the brain science behind the disease, and it will talk about the medications and how the medications work. The second one, the second video, is about outpatient treatment. Outpatient treatment is really critical in the treatment system in order to ensure access. Most people, like they would access treatment for their hypertension, for their diabetes, should access treatment in their community where they're supported, where they live, where they know the practitioners. Folks often think that residential treatment is the only kind of treatment that they should have. But outpatient treatment in the community has great outcomes and great evidence. And so you'll see through this video an example of how treatment works in the community, and follows David, the star of our video, and Dr. Ingvild Olsen, who is a practitioner. They live in Baltimore, and I think you'll find this a great learning experience. I also encourage you to share these videos with folks who would like a little bit more knowledge. Education is the best way to reduce stigma. Once people understand the disease and they understand the treatment, people, both patients, family members, and folks who are skeptical can learn quite a bit from these videos. So the next slide. So as I mentioned before, there's three, and this is a very technical slide. I won't quiz you on it, so you won't have a quiz for your CEUs on this, but we can also make this slide available. There's three different medications, FDA-approved medications for opioid use disorder: methadone, buprenorphine, and naltrexone. You might know buprenorphine as Suboxone, you might have heard that, Sublocade, and naltrexone you might know as Vivitrol. So I'm just going to leave it at that. They are also described in the videos there, but we can also make this slide available to anybody who feels that they could benefit or would like to share it with folks who would like a little deeper understanding of the FDA-approved medications. Next slide. So this leads us to where we are today. And the reason that we are in New Jersey doing our work in New Jersey focuses on the criminal justice system and correctional settings, both medications behind bars and connecting people to care as they transition into the community. New Jersey is really a great state because we have bail reform. I think we are the first state who has implemented full bail reform, and that's fantastic for New Jersey. And we should, really be proud of that. It also creates opportunity that we need to treat people quickly because we see and engage people quickly because we know that they're going through the criminal justice system at a little bit of a different pace than in states where there is no bail reform. So our work in New Jersey has focused specifically on the correctional system. Our work in other states has focused on a number of different things. But I'm going to turn it over to Brendan, who can actually walk you through the work that we've done in New Jersey. And then again, if you have questions, please put them in the Q&A function. Thanks.
Thank you, Beth. And you can take us to the next slide, Angela. So as Beth mentioned, we came to New Jersey in mid-2019. I should start out by saying that Pew's work in New Jersey is also funded by Bloomberg Philanthropies. It's through a partnership that Bloomberg has brought to bear against the opioid overdose epidemic. And we've been working closely with the Johns Hopkins University. So in mid-2019, Pew received an invitation from Governor Murphy, Senate President Sweeney, and Speaker Coughlin to really come into the state and help support the expansion of medications for opioid use disorder in jail settings. Each of these leaders recognized the strategic importance of bringing these opioid treatment services to jails and some of the challenges. And that's really why they invited Pew in to offer assistance. Beth mentioned a couple of the situational or landscape settings or things that were happening in New Jersey that made this particularly interesting. One that she mentioned was sort of the unique situation of bail reform, and that was an area that Pew had not worked in before. And it was interesting to us to think about how do you operationalize these medications in jails with folks really coming in and out of the jails within 48 hours. Another thing that was interesting in New Jersey is the state's long-term focus and commitment to this work. The state had already supported the expansion of these opioid addiction treatment medications into the Department of Corrections, but had not yet done it to the jails. We knew that working in the jails would require sort of a county by county analysis of what was needed. Each county is doing something differently, and there's a different setting in the county in terms of how those counties are interacting together in the larger treatment system, that between sort of the jails and the community treatment centers that are nearby. What was also exciting was, New Jersey's commitment to funding sort of statewide expansion in the county. So the state had made available funding that could go directly to county jails to help incentivize and expand access to these life-saving opioid treatment medications. The lead agency that the state had charged with sort of overseeing this was the New Jersey Division of Mental Health and Addiction Services. They were working in collaboration, or they are working in collaborations with the Department of Corrections and the Department of Health. And that's really where Pew was asked to come in and support. Next slide, please. So our scope of work for Pew and Hopkins had 5 areas, or has 5 areas. The first 2 are very interrelated: jail surveys and in-depth interviews. And that was really for us to understand in each jail how opioid treatment medications were offered. So we were doing a jail by jail assessment to see if somebody entered into a jail, how would they be assessed to participate in treatment? What type of medications would be offered in that jail? What type of practices does the jail have? Are they guided by best practices? Where are the areas for expansion and growth? The other end of sort of our assessment was really understanding reentry. Again, with bail reform, we wanted to get a strong sense of how these jails are integrated into the community treatment system, so that when folks are moving between the jail, moving back to the community and back and forth, we're ensuring that there's a continuance of treatment. So those first 2 areas, our goal was really to summarize county by county these jail treatment programs, understand some of the barriers and facilitators to treatment, and see how we could support in expanding that treatment. The third area on this page was correctional officer training. We knew that staff buy-in was really critical to the success of this program at the county jail level. We contracted with Rutgers University to develop a training for correctional officers. This was actually based on a training that Rutgers had done when the Department of Corrections had previously expanded medications. And we targeted correctional officers because they play a key role in helping individuals in jails access treatment. The training was meant to really give them information about what opioid use disorders are, what the role of correctional officers are in helping individuals in jails access treatment. For example, being able to understand the signs of withdrawal and knowing how to get individuals in the jail to medical staff, and some of the benefits that jails see when they implement medication for opioid use disorder treatment, things like reduced disciplinary tickets. Next slide, please. The last two areas of our technical assistance have centered around one, again, reentry technical assistance. How can we stop overdose deaths when folks are sort of reentering the community from jails? How can we stop the cycle of reincarceration through treatment? And there's really a big role here for county leaders to collaborate with jails. Things like ensuring medication activation is smooth, Medicaid activation is smooth, and care continuation from different settings, jail to community. And then the last area was data collection technical assistance. As part of the state grant money, there was a reporting requirement that each jail had to submit to the Division of Mental Health and Addiction Services, talking about what services they were offering, how they sort of expanded those services, and jails were required to submit this monthly. We knew that jails, several jails didn't even have electronic systems where they could track this information, and we wanted to create a tool that could help meet that requirement. Additionally, we wanted to expand out, and so we developed a tool that included some performance measures, so jails would be able to benchmark sort of how their medications were impacting their jail populations and making a difference. This tool has been piloted in several jails and actually was informed from some of the work that some of the leading jails around New Jersey were already doing in their counties. Next slide, please. Oh, and I'll just mention that all of this happened, of course, in the midst of COVID-19. So we had to readjust a little bit, and we were very thankful that our funder, Bloomberg Philanthropies, was able to allow us to extend our stay longer. And we still have several months where we're going to be working in New Jersey due to some of the circumstances. So this slide is just showing at a high level some of the need for jail opioid use disorder treatment, why it's important. I'll just highlight that jails are really poised to be an intervention site for treating SUD and helping stop the cycle of reincarceration through treatment. We've also seen that engaging folks in treatment through jails is really critical to stopping community overdose deaths. And if those life-saving benefits of stopping overdose are not enough, there's also economic, community safety, and larger societal benefits from jails offering opioid medication treatment. Lastly, there's some new lawsuits that are cropping up. It's recognized that offering these medications for folks with opioid use disorder is really critical and a standard of care. So it's really important that jails start adopting these practices. Next slide, please. So just going in a little bit more detail to some of those high-level points, this slide sort of outlines why jails are the perfect intervention site. More than half of the individuals who are in state prisons or jail populations meet the criteria for substance use disorder. That really compares to about 5% of the general population. So jails really are a critical site for getting people onto long life-saving treatment and starting that treatment. Interestingly, despite that high prevalence of individuals meeting the criteria in jails, most jails across the US do not offer these FDA-approved and life-saving treatment medications, that being, again, methadone, buprenorphine, and naltrexone. And when they're offered, usually jails tend to offer only one formulation and a non-agonist formulation of that treatment. We know that it's very important for each medication to be available, not only because patient choice is really important when entering into treatment, but also because each medication is a little bit different and there are pros and cons based on the individual's condition. Next slide, please. And this one just gives sort of an overview of some of the risks of not engaging. So you can see in North Carolina, one study found that there was a 40 times increase in overdose deaths among those who were formerly incarcerated compared to the general population. Again, a Washington state study found a very similar finding where drug overdose was the leading cause of death. The addition that the Washington state study highlights is that that risk of overdose is really high when somebody is leaving the jail sort of immediately upon reentry. And again, that's where I think counties play a really important role in looking at their treatment system holistically and ensuring that the linkage between treatment is very strong. We know that nationally about 128 people die per day from overdose, and a large portion of those are individuals who have justice system involvement, really making the importance of engaging in the setting very critical. Next slide, please. And this is really why you want to do this from an outcome standpoint. Rhode Island was one of the first states to really pioneer implementing medication for opioid use disorder in their jail setting. And 1 year after they implemented it, they noticed that there was a 61% decrease in post-incarceration overdose deaths. And across the state, that translated to a 12% decrease in overall state overdose deaths. So again, in addition to these life-saving benefits of these medications, there's also broader sort of economic and societal benefits from offering this treatment. Next slide, please. Over these next 3 slides, I'm just going to give each person attending here sort of a checklist of what to look for in their communities. And my ask is that each of you sort of go back to your communities and use these next 3 slides to see what's happening in your jail treatment system, what type of services are being offered, and also in your overall treatment system in your county. You know, how is that linkage going? How are you supporting jails in both offering medications, but also making a strong connection? So just at a high level, you know, universal screening for folks upon jail entry is very important to identify if there is an opioid use disorder because of the high prevalence. This should be done for everyone. All jails should have the capacity to initiate and continue these FDA-approved and life-saving medications for opioid use disorder. There should be comprehensive discharge planning. Again, this is really important in New Jersey with bail reform, and a really important part for the community treatment system to think about. You know, how is your community involved in and supporting discharge planning? Are folks really trying to be proactive and support treatment visits being set up before somebody leaves? How do you make that happen? And then lastly, sort of prescription take-home or bridge medications, naloxone, and that community appointment provided upon discharge. That's really important because there's often a gap between an individual leaving a jail and going to their first treatment in the community, and that gap is really where the risk is highest. I'm going to touch a little bit on naloxone here because we haven't mentioned that. Naloxone is an overdose reversal medication. We know relapse is part of the disease of addiction, just like somebody who has diabetes might break their diet that the doctor has recommended. People with substance use often relapse, and having naloxone around can really reduce the deadly consequences of that relapse and ensure that people can go back to treatment, go back to their lives, and continue a healthy life. Next slide, please. Another 2 areas really to check in with your community. One is that individuals in jails do have insurance coverage upon leaving. A big area is ensuring people are eligible for Medicaid. Some of the leading jails, you know, are able to get that provisional Medicaid approval when individuals are already in the jail setting, so they're already set up. When they leave, they're informing individuals of their active status at time of release. This was something that is crucial, again, to ensuring that care continuity. And then lastly, doing this statewide data infrastructure, facilitating the exchange of information so you can really track not only the medical outcomes and how the population's medical treatment is occurring across these different settings, but also things like housing, food security, and employment. The best systems are really tracking this holistically so they can meet all the needs of the individual and give everyone the best chance of living a healthy life by organizing community resources around individuals when they enter jails. Next slide, please. So this sort of recaps some of the best practices that we found, but a little bit specific to what we identified in New Jersey. It's very interesting because, again, this treatment is sort of new for jail settings. Each county jail is in a very different state of practice. We found that some of the jails, don't have any programs. Some are just starting, and some are very advanced. There's again a collection of best practices that the jails in New Jersey are doing. I'll just highlight some of them that I think are most important in New Jersey because of the unique context. Bail reform, again, makes people moving in and out. So we found that the most effective jails had at booking sort of implemented a couple best practices. One was, again, the identification and immediate initiation or continuation of these treatments. Not knowing when somebody might be leaving the jail meant that starting folks on an agonist treatment like buprenorphine was something that could end up saving that person's life should they be leaving within 2 hours or 4 hours from entering the jail. So it's really important in New Jersey specifically that identification, initiation, and continuation of this treatment sort of happens right away. Similarly, that linkage to the community, reentry and discharge planning occurs right immediately upon booking. That was one of the biggest challenges we heard when we were talking with these different jails. Lots of folks were saying, how do we ensure that, when someone gets in, we're able to get them synced up with the community treatment provider, help them get to that. A lot of the jails had implemented things like offering bridge doses or scripts. A bridge dose is, several doses of a medication that actually an individual can walk out of the jail at, so that they're, when they enter the community, they have doses that will help them be able to bridge the time between their first community treatment. And several New Jersey jails have reported that they had implemented this bridge dose practice because they had some challenges with Medicaid activation. And again, that would be sort of an area, I think, for every county leader here to check on. How does medication activation work between somebody leaving the jail and entering the community? Because of federal law currently, when folks sort of enter into jails, their Medicaid is suspended. And sometimes the reactivation of that service can make it challenging for people to get treatment once they enter community. Some of the counties have figured out how to do this seamlessly. Some of the counties needed to work on this and highlighted that as an area they wanted to focus on. So that would be something we'd ask that you sort of take that back to the community and check in and work with your jails. Next slide, please. So where is Pew right now? We did finish up the jail surveys and interview findings. I just shared with you some of the highlights from those. We're documenting these and creating some forms and information to share with our state partners. And we're actually going to create a research publication that will showcase sort of what New Jersey is leading our nation in, highlighting some of the barriers and facilitators to offering OUD treatment. Really what New Jersey is doing through this infusion of funding at the state level is a unique and powerful tool that we're hoping other states will consider because of the importance of this medication to opioid use disorder treatment and the lack of this treatment in jail settings, despite the high prevalence of individuals in jails who really need opioid use treatment. We're also working with Rutgers right now to develop that correctional officer training. It's going to be a train the trainer model. So we'll be working with each jail's trainer to get them trained up on how to train correctional officers. And then we'll work across each jail to offer this treatment. offer this training. You can imagine it was difficult with COVID to get this up and running quickly. So we've had to revise our plans a little bit, and we're actually going to end up offering it virtually soon, so that it can be delivered in each jail. Lastly, we're supporting a jail reentry council group. This is really a group that we're hoping will be, its members will be reentry coordinators within each county jail, so that they can work across each county to share best practices and help support that strong community linkage when individuals are leaving jails because, again, of that context of bail reform. Next slide, please. I'll just pause before we get to questions and encourage you all to start thinking about those questions at this moment and putting them in the Q&A box for us, to say a big thank you to each of you for attending and your time here, and also to our partners in the state. It's been wonderful to work with the New Jersey Division of Mental Health and Addiction Services. They've been very strong partners, helping connect you with each of the jails, and through their contracting efforts with the jails, we are noticing there's been sort of a shift and a focus on offering these medications. I also want to recognize the New Jersey Jail Wardens Association. The leader of this organization, Warden Charitable, has been a champion of adopting these opioid addiction treatment medications, and that type of support from somebody within the jail setting is really critical to expanding access to this type of medication, reducing some of the stigma around addiction, and it's made our job a lot easier having that support. Lastly, I want to recognize the New Jersey Centers of Excellence. That's Rutgers in the north and Rowan and Cooper in the south. They've been great supporters to us and helping the jails really implement best medical practices. Some of the jails, through this collaboration with the Centers of Excellence, have done really leading things that we're not seeing happening in other places, like offering an injectable form of buprenorphine in a jail setting to help sort of pilot that use of that formulation of this medication. Next slide, please. And with that, I'll turn it over to John to help facilitate question and answers. And just mention that we've got our contact information here. Don't hesitate to reach out to Beth or me. And you should have access to the documents in the chat box from Angela. She's facilitating the video, and we'll be sharing some of this afterwards. Thank you.
Great, thank you, Brendan and Beth. I appreciate it. That was very helpful. I have a couple of follow-up questions for you. Is there, and this is always an important issue, despite the fact that we're now flush with cash in New Jersey, is there funding available? And let's talk about pre-COVID, and let's take the federal stimulus monies that are coming, to the state out of the equation. Is there monies available to the counties that agree to move forward with the Pew Charitable Trust program here?
So this was an initiative begun by the Department of Human Services, who used a portion of some federal funding and some state funding and provided that to the counties to work on this. So part through the MADI program, and we come to the state free of charge, and we have paid for the training and some ancillary services, but the funding to the jail would come from Human Services. And you're right to acknowledge that there's a number of opportunities with a lot of the COVID packages that have been recently assigned into law. So one that was prior to, the current one is the American Rescue Plan. Prior to that, the prior COVID package, there was a substantial amount of money that was allocated to SAMHSA that would go down to the states for use in a number of areas. In addition, on the horizon are the opioid settlements that are happening, against some of the big manufacturers and others. So you might be familiar with the recent McKenzie settlement, and then the Sackler settlement that's coming through. And so these funds will also be available to the states, and we support that. The funding coming down from the opioid settlements should be used to address the opioid crisis. We saw during the tobacco settlement when the lawsuits against big tobacco, a lot of those funds were supposed to be used by states to actually fund initiatives around tobacco, and a lot of them weren't. They were sucked up by the general fund. And so we really encourage states and support states that want to take this funding and use it for evidence-based treatment to address opioids. And certainly, I see no reason why that money couldn't go to the counties.
Great. Do you have a resource that you can share with us to show where all of those, that funding would be available? Is that on your website, or is that something that we should work through, the Department of Human Services?
So the lawsuits are through the Attorney General's office. And so I would encourage you all to work with the Attorney General's office, because they're the ones that are negotiating for each state the settlement dollars. The other ones are, we can find the links to I can send you the links to the federal, for the federal dollars. SAMHSA hasn't allocated them, to the best of my knowledge. That the last COVID package before the most current one happened pretty quickly at the end of the last administration. And so I don't believe, it's not, to my knowledge, SAMHSA has not issued any of the guidance on how they will distribute the funding. There was also more money for SAMHSA in the newest package. Some of that was centered on harm reduction, so certain services programs, and naloxone and other types of harm reduction services. But again, SAMHSA hasn't released the parameters by which they'll be distributing that to the states. But that money will come through the Department of Human Services.
Great, thank you. I appreciate it. Now, I have more of a practical question for you. In working with the county jails, what type of individual is eligible for these services? Because as you know, in working with Warden Caldwell and the County Jail Wardens Association, which is just an outstanding organization that we do a lot of great work with them, together. So what type of individual is eligible? I mean, the county jail prison population is a very transient one. As you know, the average length of stay is anywhere between 5 to 10 days, with, I think 85 to 90% of those inmates either awaiting their first appearance or pending a trial. So who again in the county jail is eligible for these services if a county is engaged in this program?
I can take that. I can start out there, Beth. So really, it's anybody who meets the criteria of an opioid use disorder. And again, that identification should happen really quickly. This is something, initiating people on these medications is something that happens quickly all the time. If you think about emergency room departments, they're often coming in there with an overdose, and the ER doc is able to give them a bridge script for buprenorphine and set them up with a community treatment pretty much immediately. So that's something that jails should be really doing as well. And we did see several New Jersey county jails that had taken the steps to do that. And so that's something that we're encouraging every New Jersey county jail to build up the capacity to do that as they start implementing these medications.
So again, just a follow-up question, even for individuals under criminal justice reform who come in the county jail and they're in and out within 48 hours, which probably makes up about 45–50% of the county jail population. So even individuals in that category would be eligible under this program? Yes. Okay.
And it's important, I know that I think Brendan mentioned this earlier, but it's really important to remember when folks are coming in, they're being screened for health services, right? For all these other things, health services when they come in. So this should be part of the screening. Is there an opioid use disorder? Because then there can be this immediate connection to care. And then this warm handoff that happens because you're right, people are exiting quickly. And so making sure that they're connected to a treatment provider in the community, which is the importance of activating Medicaid, or making sure that Medicaid, people are PE, presumptively eligible, really does then connect them back to care. So you reduce the opportunity for an overdose and then an overdose death, because folks are back in the community without a medication or a connection to medication. And it's important too when people are coming into the jails that there'd be, for folks who, even if you're there 5, 10 days, some people are there longer, that they can continue the medications that they're on. There's been a number of lawsuits, Massachusetts, Maine, somewhere else in New England, where jails have been sued because people are coming into the jail system. They're using buprenorphine or methadone, and when they enter the jail, that access to that medication is curtailed, and so they are being cut off from their medication. And you would never cut off someone with hypertension from their hypertension medication when they walk into a jail setting. And so these lawsuits have found in favor of the patient, and has required the jails to actually continue treatment for people who are entering while utilizing treatment.
So I have, go ahead, Brendan. I'm sorry. You look like you wanted to add something.
I was going to say, in researching, how Pew would sort of engage in this space and talking to experts around the nation, one of the interviews we did was actually with the Philadelphia Department of Prisons. Bruce Herdman is a leader there. And he said, his way of looking at jails is as an intervention site. It's for people who haven't been able to find the service they needed in the community. Those are the folks who end up in the jail. And I thought that was such a wonderful way of looking at that, because jails can be that point of connection. And we know that when you look at jail populations, there is sort of this cycle of reincarceration that tends to happen, but that can be interrupted if the jail is really thinking about using this point in a person's life to get them back on track.
So I have another follow-up question. I hope you don't mind. And I'm asking because we've been for a couple of years working with the county jail wardens and our Welfare Directors Association on legislation that would, I guess, extend the prisoner reentry services, both for the state prison system and our county jails. And one of the points that we're kind of held up on is who in the prison population these reentry services should apply, which this program, of course, would count. But how long are the prescriptions written for, if I'm asking that question correctly? Because the legislation would require, upon the release from a county jail or state prison, that the prison or jail would have to write a script for 30 days for prescription meds. 90 days, not 30 days. So I think typically in the county jails, we're looking at anywhere between 7 or 14 days. What's your standard operating procedure for writing that prescription?
So it depends on the medication. First of all, it depends on the medication. And then there's rules around the different types of medication. So there's not one rule that can be put across for all medications. The script is, you can get a script for naltrexone and you can get a script for buprenorphine. In order to get a script for buprenorphine, you have to have a waivered doc being able to write it, which is, that is one issue. Docs are also, there's lots of rules around how the prescriptions that docs can write. And then if a patient is using methadone, then methadone is different because you have to go to the OTP. The connection to care, the more quickly the connection to care can be realized, the better off for the patient. And the more likely they will be to utilize and to adhere to their medication regimen, but it also gets them into the community, attaches them to the community provider. So really, time is of the essence. So you want the patient to really connect with the practitioner as quickly as possible.
And just to add a little bit onto that from sort of a medical standpoint, folks who are using opioids illicitly and have an addiction and enter into a jail, for folks who sort of undergo withdrawal and are taken off that use or aren't provided medication to help support them, they enter a very dangerous phase in their life, because when you're using regularly, you get a certain level of tolerance to these substances that just disappears. And that's why when folks enter into the community without the supportive treatment, without the support of these medications, they might go back to using the same dose they did in the past, and that dose then causes them an overdose, whereas previously it wouldn't. So it really is important that these medications are offered sort of immediately upon somebody's entering, that folks aren't put through withdrawal unless it's deemed a medical preference to do that, and that they're entered onto treatment really quickly to prevent that high risk of overdose.
Great, thank you. We're gonna, Beth and Brendan, we'll have to have a follow-up conversation, because I think I might need, we might need your help on, we've been advocating for this county reentry coordinator position in every single county that I think would help to serve, kind of navigate the services available, all of the social services that might be available and resources available to an inmate upon, their release from the jail or prison at the county level. There's currently not that. The county jails and our boards of social services and welfare directors, welfare agencies work very well, together, but we kind of think that there should be that nexus between the two to kind of help navigate all of those services. So I want to share with you, the proposed legislation that we've put out there. That's going to need some funding for that particular position, but I think it falls in line with what you're looking to do and could be helpful. So we'll have a conversation after this video conference. And I think we do have a question. Okay, is there advocacy to waive the IMDS exclusion that historically disallows jails from being, this is a great question, from being able to bill Medicaid? If a waiver is granted, perhaps jails can do presumptive eligibility right at admission. This will allow jails to bill for services provided behind the wall and will ensure the inmate signed up for Medicaid before they are released.
So actually, in order for folks to you get coverage behind bars, it would require a waiver. So through the 1115 waiver process, a number of states have asked CMS for permission to bill Medicaid for services behind bars. This has, CMS has sat on these requests. So New York has one, Kentucky has one. There's a number of states that have submitted an 1115 waiver request to do just this. New York's is very broad, Kentucky's is very narrow, but still CMS has not opined on these waivers. There is a bill in Congress called the Medicaid Reentry Act, and this act would permit Medicaid coverage for 30 days prior to release. And that would then cover Medicaid services. It had been part of the American Rescue Plan. And if you recall, perhaps all the talk about the rescue plan and the talk about the minimum wage, and they said the minimum wage was taken out by the Senate parliamentarian because it didn't meet the criteria to be in a reconciliation bill. This particular Medicaid Reentry Act fell the same fate. So it was in there, and then the parliamentarian took it out. But it is still an active bill in Congress, and definitely something to look at that would cover at least 30 days. It's expensive. So that, I'm sure CMS looks at that, because we're not just talking about substance use services, right? We're talking about all medical services that would happen behind bars. The other thing that I've heard from the advocates that I speak to is that also CMS needs to really contemplate what are the safeguards and what are the structure that should be set up for this reimbursement. If you look across the country, and I'm not saying this is true in New Jersey, but if you look at some states across the country, the care for people incarcerated is really poor. It's actually, and I'm sure folks, you can read this in the paper, you hear these horrifying, read these horrifying reports of how their medical treatment is or is not provided. with the great care that it should be. And so Medicaid, CMS would also like to get this right, because they don't want to just start reimbursing for terrible care, because that doesn't help anybody get the care that they need. So, on the CMS side, they really need to set up the standards by which they will reimburse for care behind bars. But you can, the Medicaid Reentry Act, it's active in Congress right now. And so folks can check that out. And I'm not sure, I can't tell you off the top of my head who the bill sponsors are, or if our New Jersey legislative contingent, congressional contingent has added on as sponsors or not. But it would be very helpful to the states, that's for sure.
Great, that's helpful, Beth. We'll make sure to follow up with that and get our congressional delegation engaged. So it looks like we have time for one more question, and that was a thank you so much. So it wasn't a question. Wait a minute. We do. Okay, this is a comment. We have the Union County Department of Corrections Reentry Coordinator connect individuals to community-based programs for medicated assistance before they leave the facility.
Fantastic.
Thank
Congrats,
you.
Union County.
Yeah.
I love it.
It's good stuff. So I think that's all we have. We're at almost 11 o'clock. I want to thank you, Brendan, and of course you, Beth, for taking the time to do this today. I appreciate it. It was very helpful. I believe the PowerPoint will make available to the folks on this call. Please check out the websites that were left in the chat room. And thank you again for your time. And this was a terrific presentation. I look forward to seeing you in person soon.
It's really our pleasure. So, and feel free to reach out to us for anything. We're happy to respond.
Great. All right.
Thank
you. All right. See you soon. Bye-bye.
Bye.